Hi guys. We'll continue our nervous system, and basically nervous system include these two branches, the motor and the sensory. So we will start by talking about the sensory, and then we will move on to the motor. So we will probably use three portions to finish this sensory part. There are a lot we can talk about in the sensory, but and we don't have a lot of time, right? So I will condense it to the most essential one, something that's more relevant to the to DPT, and hopefully this will give you a glimpse about what is the amazing part, what's the amazing portion in the sensory system. So as you can tell, this is a human brain. And here we identify the region of the human sensory, cortex. And so you can see that a lot of these regions are not sensory, but the major sensory areas are what? In the somatosensory. So this is a region that um, analyze our received sensory in our skin, right? Through the spinal cord, send signal into the brain. This is region that it process this signal. We also have the gustatory, the taste, the auditory, the vestibular right here. Very close, we have the olfactory, right? This is for the smell. In addition to these regions, we also have one very large area to process the vision. So, so if in our brain, human particular, we are very feeling oriented and also visual oriented. Uh, and uh, so if we have time, we will talk all this. Since we are time limited, we will focus on the somatosensory and also the visual system to give us some idea about what are the sensory function is processed in the brain. So this one showing you that different signal input into the major sensory cortex receive signal from our peripheral. The vision coming from the eye, the primary somatosensory cortex coming from our skin, and this one through the organ is in the skin, tongue, and the receptor are mechanoreceptor. So we will start by talking about this one. Then we will talk about that vision. This is a big portion in our brain to process the vision from the light track through the eye. And here we have the photoreceptor to detect the photon and stimulate this light and send signal into. In addition to that, we also have a nose. This is the organ is nose. Olfactory receptor. This one is the chemoreceptor, so detect the chemical sent to the olfactory bulb to the olfactory cortex. The auditory, the hearing, is also mechanoreceptor that the hair cell receive. We are very good at hearing as well, but the cortex to process is not very huge in terms of the sizes. And we have the test. Test is also a process. It's also a chemoreceptor located in the tongue, mouth wall, and esophagus. All this region contains taste buds. Receptor is chemoreceptor, so and the signal process sent to the this region in the brain. All right, so we will start by looking at this one here that basically go through here. We will look into the receptor and the pathway. We will then look into this one here. We will then look into the photoreceptor and the pathway, and then we will talk about this sensory cortex in the primary, somatic, sensory, and the visual. So that's these two. All right, let's start by the first one, somatosensory system. The receptor is the sensory neuron carry that receptor. The function of the receptor overall in the sensory nervous system is that the function of the receptor is to transduce non-electrical signal to the electrical signal, because only when it's becoming an action potential, it will be taken into the nervous system and processed in the brain. And to transform that, we need a transducer, and this is the function of the receptor. In the somatosensory system, except the free nerve ending, this one is the nociceptor. This one can be stimulated by three major modality, including the mechanical, so if anything sharp, you will feel pain, including the chemical, so chemical cause can stimulate this painful feeling, right? And also like acidic level, high acidic level can trigger that. And also the temperature can also stimulate the free nerve ending. So except free nerve ending, other somatic sensory receptors are all mechanoreceptor, meaning that they get stimulated via physical bending, physical touch, right? So that's that. We will learn these two M's, Messener's, Corpuscle, Merkel's disc, hair end organ, then Ruffini. So the orientation, the way I organize this basically is from the surface to the deeper tissue. So in the skin, right? So free nerve ending is very superficial. And this can be stimulated by three major modality. Underneath that, we will see the Messener and the Merkel's. Hair end, we will have this hair end organ. So when hair is bended, it will trigger this one. And further down the skin, we have the Ruffini's and the Pacinial corpuscle. And then this is not skin, this is in the muscle and the muscle tendon. We have the muscle spindles. We have the primary and the secondary ending of the muscle spindles. We also have the Golgi tendon organ. So that's that. This is just give you an idea that what they look like and what they are located. From the top, we see this free nerve ending. Then we can see these Messeners, right? A little bit lower than the free nerve ending. Here it doesn't say the Merkel right here. So it's very much the same level. Then deeper region, we have this, we don't talk about this cross and bob, but we do talk about this Pacinian and Ruffinian. So these are the deeper region. So that's that. Here we have the hair end organ, right? So sensory neuron is a neuron. And so we learned about neuron. A typical neuron, we have the soma, the cell body, and we have the dendrites to receive the signal. Action potential travel from the initial segment of the axon toward the axonal terminal. So that is a typical neuron. Now, the sensory neuron will not have the dendrite because it's not connected with other neurons. It's already in the terminal of the body. They are in the border of the body. So these dendrites are becoming the receptor. So we have, this will become the receptor here. And everything else would be the same. Dendrites, cell body, axons. Here is the spinal cord. Get into the spinal cord. One thing that you need to know is that even though there are many types of the receptor, each receptor would the only same type of receptor coming from the same neuron. So it's not like same neuron can have branches of different type of receptor. So it's very much like we have different receptor. They are like different fruit. And so you won't see one tree have different kind of fruit, right? The same tree will have only same fruit. And so this receptor would represent different neurons, different receptor represent different neurons. And this neuron not only different in receptors, they also different in the axon fibers. So the type of the axon fiber here is the primary afferent axon. So that's the coming in. So this basically the type of the neuron we are talking about, the sensory neuron, right? Because that is a signal coming into the body. It's coming into the body. If it's coming out, it will be the motor neuron, right? So this is the coming in. And the type of the axon can be classified into these four types: A, alpha, beta, delta, and C. C is one without myelin. A is one with myelin. So type A is a myelinated axon. Type C is non-myelinated. And the thickness of these axons also indicate how fast they can transmit the signal. And so if this is A alpha, it's very thick, so it can transmit signal faster with the myelin. And so the thickness is A alpha larger than A beta, larger than A delta, larger than C. And the speed, it will follow the same order. A alpha faster than A beta, faster than A delta, faster than C. So that's so sometimes when I have a quiz question that I ask which one is the fastest, people got it wrong. You know, I was kind of surprised. I thought that was an easy question. And which one is myelinated? Which one is thickest, right? So I have this four option there. People got it wrong. I thought that's an easy question. Anyway, all right. So when we have these receptors are typically a mechanoreceptor receptor. So how it does is that this, for example, this is the Pacinian corpuscle, a type of the receptor right here. When a pressure applied to it, it will cause morphological change. So it will be banded. When it's banded, the membrane will become more porous, and it will allow the sodium coming in because inside is negative. So when it's opening a little bit, when ion can be freely diffused in and out, the sodium will go in more than potassium going out because inside is negative. So sodium is positive charge ion will go in. And then it will trigger a receptor potential. So that is the membrane potential difference, membrane potential change due to these stimulus. These stimulus may not be strong enough. So this receptor potential may not be high enough to be above the threshold. Only if it's above the threshold, it can trigger an action potential. So here we have two potentials right here, receptor potential and the action potential. Only when the stimulus is strong enough trigger this receptor potential above the threshold, it will then trigger an action potential. And then this action potential will travel from the dendrites toward the axon terminal. So because different receptor come with different nerve fiber, and so we sometimes see in the textbook that they don't call it specific type of receptor. They call it, say, type 1A receptor, type 1B, as a way to describe that it is, say, type 1A is the muscle spindle, type 1B is the Golgi tendon organ, something like that. So it's type 1A receptor signal, type 1A sensory signal would be the muscle spindle signal. Type 1B would be the Golgi tendon organ. So these are commonly seen. Type 2 is the secondary endings of the muscle spindle. Type 4 is the non-myelinated fiber. Non-myelinated fiber usually is and also type C will be the same. So to classify the fiber types, we can classify them as type A versus type C, the myelinated versus non-myelinated. In the sensory though, we can also classify as type 1, type 2, type 3, and type 4. So these are basically you can kind of pair to each other. That is just two different ways to say the same thing. And it really depends on the context that a different field will say it differently. So that's that. Now let's start by looking at each of these receptors. So free nerve ending. Free nerve ending are the nerve ending serve as touch. You can have that crude touch through the free nerve ending. Free nerve ending usually is not very precise in terms of the location. This is the most superficial receptor among all tactile receptor. It's sensitive to the crude touch and also pain. So this is also the type of receptor for the nociception, the pain receptor. It has two types of fiber, type A delta and type C. A delta is the myelinated one, faster than type C, the non-myelinated one. All right, so the following that we have these two M, Messenger and the Merkels. These two are located relatively in the same level of the depth in the skin. So they are very much see the similar penetration of the pressure from the skin. So why do we need two? It's because one has high adaptation, the other one has slow adaptation. So that's the reason of these two. Adaptation means that it will become non-sensitive after a constant stimulus. For example, a fast adaptation is that, say, you go into say you put your glasses on, right? Like I have my glasses, I put my glasses on. At the moment, I feel it, but give it time, I don't feel it. You have that kind of experience, right? This very typical experience that you would ask that, where is my hat? It's right there, right? So it's on your head. You are wearing it, right? So that's the adaptation. Some receptor adapt fast, some receptor adapt slow. And we need both. We need some receptor, don't keep bothering us with a constant stimulus. We need focusing on our life, right? We don't really want to feel our glasses or hats. We want to feel something more interesting, right? And so we need that. But we also need some constant uh, reminder that we are sitting, the pressure is on us. And also that, yeah, so we need some slow adapting receptor, but we also need some faster adapting receptors. And that's why we have these two types in the same level, but different receptors. So the easy way to memorize it, the way that I memorize it is that these are two M's. So this is following the visual nerve ending. We have these two M, Messeners and the Merkels. And we all know who is Merkels, right? And considerably, slow adaptation, not saying that she's slow adapting, okay? Just a visual, like a way to help you to get the connection. And so Messenger is a fast adaptation. It can distinguish the uh, like surface differences, and the Merkels is a way to detect a constant, continuous touch. Both transmit signals through A beta, so these are all very fast, uh, send signal into the brain. So that is this one here, Messengers and Merkels right here. They are all like same level. Here they all seem like they all growing from the same tree. It's not right, okay? This is just a bundle of the fiber. This one is one fiber, this one is another fiber. So it's not like two branches, okay? So don't get confused by this cartoon drawing. Following that, we have these two, Raffini and Cassini. So you can imagine that same technology, same scenario will apply. One adapt faster, the other one adapt slow. So before we go into the Ruffinian and Pacinian, I also want to introduce one special region. This is called egodome. Egodome is a extrusion in the skin, and this one basically provide enhanced touch of this Merkel's disk. So underneath this egodome, we have a group of the Merkel's disk. All right, so Ruffini and Pacinian. Let me pause. I want to see what's happening with my. Yeah. So these two, the same level, and Pacinian is one adapt fast. Ruffini is one adapt slow. And these two, so one can detect when it's adapt fast. The one adapt fast can detect the change, can detect the higher frequency of the differences. The one adapt slow can detect the constant or continuous status of the pressure. So Raffini are the one can detect the continuous pressure, and because they are deep in the skin, they can also feel the degree of the joint rotation. But the Pacinian adapt faster, can adapt the movements and the vibration. All right, so this one showing you that these five major somatoreceptor that we have described, free nerve ending. So from the surface to the deep tissue, free nerve ending, and Messina and the Merkels. So because they are more superficial, they can detect the texture. Messina detect the fine texture. Merkels detect the smoothness of the texture. The continuous pressure, or the the continuous feeling of the touch. Ruthenian and the Pacinian are deeper. Ruthenian and Pacinian are deeper, so this force has to penetrate further down. So when they may detect it, it will become the one that will be viewed as the pressure, because this is not just the touch, this is already penetrated further down here, and also the vibration propagate down here. The constant pressure will be felt by the Ruffini. The vibration, that is the changes of the on-off can be detected by the Pacinian. So all this can be viewed as different depths in the skin, as well as different adaptation. So here showing you that different receptor can have different adaptation. For example, if we have the constant stimulus over time, 1 second, 2 seconds, for the Pacinian, less than say 0.1 second, impulse per second drop to 0. So it doesn't send signal to the brain anymore. Adapt very fast. Hair receptor adapt about a minute later. So when you put your head on, your head and organ would not feel it a second later. Other adapt slower, like joint capsule receptor. This is Ruthenian. And also muscle spindle. This one adapts slow. These are especially important because we need the signal from our, even though you probably don't really aware, you are not aware of this feeling, like the one in the joint capsule receptor of Ruthenians or muscle spindle, but part of our brain take those information to conduct a movement, because our brain need to know where are they located, where is our fingers, where are our arms, our fingers, our legs. So they need to get that information, and so this receptor cannot stop working. They have to continuously send signal into the brain. So this one will adapt slower. Two type receptor, slow adapting receptor and a fast adapting receptor. For example, this one is the slow adapting receptor. So it doesn't stop working, right? This one is also called a tonic receptor. Here is a stimulus into the nerve, and it will, as long as the stimulus is on, it will generate action potential continuously. So even though it gradually drops, it will be highly intense signal in the beginning, but the feeling gradually decrease. However, it's not completely gone. And this is the end plate, this is the receptor potential. It will trigger the action potential into the brain. This is impulse. As for the fast adapting receptor, they will very quickly stop working like a second later. So when we provide the stimulus, it will change it, provide an action potential rapidly. However, the impulse this receptor potential very quickly drop to 0. So our brain will feel it when we touch it and don't feel it at all. So during that constant touch or constant stimulus, it doesn't send signal at all. So this is the, and then when it's off, we take it out. And again, this morphological change, sending another receptor potential, sending another impulse, and we will feel it again. So this fast adapting receptor is a good one to detect a change, status change. It's 0, it's on. When it's on, we know. When it's on, from on to off, we know. And so this can detect the phase or status difference. And this will be the good one to tell the vibration. When it's on, off, tell us again. When it's on, off, tell us again. In contrast, if it's still adapting, when it's on, off, it will take some time to turn off. And it's on again, we probably won't even tell the difference. It will be on or over in terms of the receptor potential and also the action potential. So the tonic receptor is a good receptor to detect a continuous status. The fast adapting, rapidly adapting receptor or the phasic receptor is one to tell the phases or one to tell the changes, the high frequency differences. So tonic receptor is one of the slow adapting receptors. Examples including the muscle spindle, Golgi tendon apparatus. This one is important to provide the proprioception, so our brain know where our bodies are located. They cannot stop sending signal. Otherwise, we don't know where they are located. Pain receptor is also tonic receptor because it's not like if you got injured, if you feel pain, it will go away. The pain signal, as long as it's stimulus, it will continuously send signal to the brain. Baroreceptor detect the blood pressure, so they can't quit, right? They have to continue send signal to the brain. But a lot of chemoreceptor in our body also is a tonic receptor. They detect the pH level, and so they have to continuously sending signal depending on to reflect the even though there's no change, the pH level can maybe always very constant, but our brain need to know. As for the phasic receptor, this one adapt faster. A typical one would be the hair end organ. This one adapt faster. Pacinian organ, cortisol adapt faster. So that's this one here. And so this one summarizes all these receptors that we mentioned about. So and distinguish them to the fast adapting receptor in this side and the slow adapting receptor in this side. So here are the list of the fast adapting receptor. Turn on, but it only sends signal maybe early second, then it stops sending signal. So these are the fast adapting receptor. Messenger's compared to the Merkel's, hair end organ or hair follicle receptor, the Pacinian, and this free nerve ending should not be. If this is the pen, it won't be adapt fast. So you can probably cross out that one. So I just correct it, and these sides are the fast adapting one. So Messenger's follicle, hair follicle receptor, Pacinians, these are known to adapt very fast. Some other actually Merkle disc, it can be fast, depending on what you compare to. So if compared to the Messengers, it will be slow, right? So that's right here, Merkel's disc. Also, the Ruffinin is slowly adapting receptor. We also has these slow adapting and fast adapting receptors serve as the receptor for the proprioception. So this include the muscle spindle. Muscle spindle is the one wrapped in the center muscle fibers. And so this is the secondary nerve ending muscle spindle. This is the primary nerve ending of the muscle spindle. So this one is slow adapting. That our brain would know where is our muscle because and how tightly that our muscle is contracting. This is Golgi tendon organ, also sends signal to the brain to provide the proprioception. We also have the Pacinian corpuscle, Ruffinius ending. These are deeper portion of the receptors. So all these four work together to provide the information of the proprioception. So this is a quiz question, okay? Which is the sensory receptor provide the proprioception? And so you need to choose from these four. These are the four major receptors to provide the proprioception. So this one summarizes it. We have different receptors from the top to the deep tissues. Some adapt fast, some adapt slow. And these four, this deep portion, deep tissue, these four are the one to provide the proprioception. Now, when we have this receptor, we detect it, send signal into the spinal cord. The next step is to transduce this signal into the brain. And this transduction pathway has two major types. One is called the DCML system, the dorsal column medial lemniscal system. And this one basically transduce all these mechanoreceptor except the free nerve ending. Another one is the lateral and anterior lateral system, ALS. This one transmit the signal from the free nerve ending. So that's this two pathway, different receptor go through different pathway. All this DCML pathway has one thing in common, that is that they are very good at spatial and intensity resolution. So it can tell the location and intensity very well. And that's what when you feel it, when you touch it, you can very much tell exactly where they are in the skin, okay? So you know your stimulus apply on the Messner's, Merkel's, Ruffini ending, Pacinian, muscle spindle, Golgi tendon organ. And the later four are important to provide proprioception. When you close your eye, you put your two fingers to each other, right? You should be able to do it. I know sometimes it's very weird when you're first doing it, but you should be able to do it. And so you have the idea that where are your fingers, even though you don't look at it. And that precision is needed. As for the other one, the ALS system, this one transduce two types of signal. One is the pain, crude touch, and temperature. So three types of signal. And this one are the major one that we talk about here is the one from the free nerve ending. And so in contrast to the DCML, free nerve ending provide this sensation doesn't come with precise localization. So when there is pain, sometimes it's very difficult to identify. In the skin, it will be easier because even though the free nerve ending is not very location specific, but it may also, when you scratch it or something, you also stimulate this tactile receptor. So you will get the idea where this pain or sensor is located. But it's still sometimes very difficult, especially like, and especially like if the pain coming from the visceral, like inner organ, it's very hard to identify the location, the source of that stimulus, what caused it, where it's located. Very difficult. So the sensory pathway from the ALS is not very location precisely. So let's start by talking about this DCML pathway, this tactile receptor, mechanoreceptor, proprioception receptor. Well, first, this is neuron located in the dorsal horn of the spinal cord. And this is a dendrite axon send signal into this axon is actually pretty long. It will have first branch into the interneuron in the spinal cord, but another branch will go all the way up to the medulla. Okay, so here is the medulla. So it will go up to the medulla. Then the second order neuron from the medulla, we have two nucleus, right? Two nuclei right here, two major nuclei right here to receive the first order neurons. And then this second order in the medulla will then cross to the opposite side through this medial lemniscus to the opposite side, and then reach to the thalamus. And from the thalamus, this is the lateral posterior lobe of the thalamus, will then has this is first, this is second, this is third. The third neuron will then send signal into the visual, the primary somatic sensory cortex. And then you can feel it, all right? So this is DCML. We later will talk about the ALS. This one will be the nociceptor and the temperature. So this one is from the free nerve ending. All right. So the DCML first order neurons are located in the dorsal root of the ganglia in the spinal cord. And they enter in this first order axon, has two major branches. One synapse with the local neuron in the spinal cord. This local neuron include the interneurons and the motor neurons. So this indicates that this receptor can trigger a motion because once you stimulate it, it will immediately trigger a motor neuron. This is called the alpha motor neuron in the spinal cord to cause muscle constriction. Another branch will then send to the brain, and this one doesn't cause the motion. This one will tell you a feeling. So send to the medulla and then spinal, and then the thalamus, then the cortex. So this one, the very first one, that when they reach to the local interneuron and the motor neuron in the same level of spinal cord, this will cause muscle constriction. And this is this is the phenomena that we call the stretch reflex or the myotatic reflex. So very much like this one here, when you stretch it, your receptor is the muscle spindle right here, will then enter into the dorsal root of the spinal cord, one branch is sending up to the medulla, and locally it will innervate with the motor neuron. So excited, stretch it, sensory signal cause it contraction. When it contracts, when muscle contract, so this is one the in the physician commonly do, that it will it's called knee jerking, that it will hit this knee and to cause a sudden stretch. This sudden stretch will trigger the muscle spindle, cause muscle constriction, and then it contract, the leg will kick, right? So that's that. This is called stretch reflex or myotatic reflex. It's induced by this reflex has input pathway from the muscle spindle. The output pathway is from the alpha motor neuron in the spinal cord. So this pathway is very simple. This only involves two neurons connect with one synapses. So this is also called the monosynaptic reflexes. So this reflex, later you will learn that there are many types of reflexes, and a lot of them, I think this is probably the only one, is monosynaptic reflex. A lot of other reflexes involve multiple neurons. And a reflex means that this is how our body responds to the environment by controlling a skeletal muscle or any muscle, because we also call the baroreceptor induced the sympathetic nerve response reflexes. So it's our body respond to the environmental change and to control our muscle. It could be the cardiac muscle, smooth muscle. In this case, it's a skeletal muscle. We all know that skeletal muscle is voluntary nervous system, but it can also be controlled by the reflex, by this one apparent. It can be viewed as an autonomic, right? This knee jerking is not like you can try to control it, but if you don't intentionally control it, it will just kick, right? So that's that. And then the second order neuron is in the medulla. Here we have two groups in the medulla. They are the nucleus cuneatus. This receives signal from the receptor in the spinal cord T6 and above. Also the nucleus gracilis. This one receives signal from the synapses in the spinal cord T6 and below. So we have two. You can see the picture here. Sensory signal, it's either into the cuneate nucleus or gracious. Cuneate is one to receive the T6 and above. Gracious is one the below spinal cord T6. And then this one will reach into the thalamus. And in particular region of thalamus is in the ventral posterior lateral region of the thalamus. The second order neuron from the medulla sends signal through the medial lemniscus to the contralateral side and then to reach the thalamus. So you can see that it's from the second order neuron. We have two cross to the other side to reach the ventral posterior region of the thalamus. And from there, it will send the third order neuron to the sensory cortex. Now let's look at this. Let's look at this thalamus. Let's look at this thalamus. So this thalamus is the, this is the thalamus. Thalamus is the hub of the brain. So it means that it's like a bus, like a central station, that everything will come in here and going out. Everything from the peripheral will come in here. So you can imagine that everything from the peripheral, meaning that all the sensory signal. Peripheral means your vision, your hearing, your somatic sensory will go in here and then go into the brain. So before they go into the brain, they gathered here in the thalamus. And so it's just very much like a central station. You have the two building, right? And the one building receive signal from spinal cord, one building receive signal from other region, right? So coming in, coming out, coming in, coming out. So here is the imaging showing you that. And what I want you to get attention is that, for example, that here is the ventral posterior lobe. This is one receive everything from the spinal cord, also from the medial, from the trigeminal nerve, lemniscus. And then it sends signal into the somatic sensory cortex. You can also see that this one ventrolateral receives signal from the cerebellum. Later we will talk about the cerebellum. And here is a signal from different other region. This from the actually globus pallidus is from the basal ganglia, and globus pallidus is from the basal ganglia. This one from the optic tract, LG lateral genetic bulb is to receive the visual signal. This one is to remember is from the auditory signal. So you can see the thalamus is like a hub. Everything will come in here before they enter into the cerebral cortex. All right, so you need to have that kind of concept that in the brain, this is the hub. I don't have the fiber, but it will be cool to see the fiber. Maybe later if I have the chance to show you that. All right, so this is then from here, it sends signal into the primary somatic sensory cortex. It's right here. In the brain, we have the central sulcus. It divided the frontal lobe and the parietal lobe. And so the sensory are all in the parietal, like the primary sensory, occipital lobe are all sensory, right, in the parietal. The frontal are more movement, action, including the motor cortex right next to the sensory cortex. Motor cortex, primary motor cortex in the frontal lobe. And further down here, further front, we have the control of some behavior, so decision making, and so this is also action. This is more like planning action. And so that's the general division of the brain cortex. The one we need to, you guys need to memorize is that the location of this primary somatic sensory cortex that is located in the parietal lobe. It's right next to the central sulcus or central fissure. This sensory cortex also organized, arranged in a way that different area responsible for different part of the sensory receptor. So that is, and also the size of that cortex represent how many receptors are used in that area. So we can see that it's not like regular people, because in our human, different skin has different density of the receptor. And now we can see that from this brain area, we get an idea that the sensory density or sensory amount is very high in our hands, in our tongues, in our lips, right? So these are regions full of the sensory. So we are very good at hand touching, and also, lips. It could be the talk, right? It could be the eating, and also eye also has some sensory. It's not vision, but our sensory in this area is also very has a lot of receptors. So we kind of know this is also related to our proprioception, that we know that kind of like where is our eye. If you close your eye, you touch your eye, you can very well touch it because we have very good proprioception over there. So that's that. And in the cortex has layers. The typical cerebral cortex has 6 layers. So in the sensory in particular, and the motor too, that we will learn in later, we will learn that all of these typically has 6 layers. The signal inputs are usually in the layer 4. It's same here in the somatic sensory cortex. It will be the same in the visual cortex. So the inputs are all in the layer 4. Yeah, so that's probably the only thing you need to know. 6 layer, 6 stellar layer, and the signal input is in the layer 4. So that's that. That was the DCML that we described. From the first order, we talk about the receptor. We talk about different type of receptor. We then talk about this pathway. Now let's look into the other one, the ALS system. This one only carry one type of receptor that we mentioned here. That is the free nerve ending. So this is the nociceptor. It's the sensory about the pain. So the difference between these two is that their first order neuron doesn't go all the way. This one will go all the way to the medulla, even though it seems very short, but in the real life, it's pretty long. Here, the first order neuron, very short. It's synapse in the spinal cord right there. And the second order neuron in the DCML, the second order neuron is in the medulla. In the ALS, this pain signal has the second order neuron start from the spinal cord. And then in the spinal cord, it will reach to the opposite side, go through this pathway up into the thalamus. And very much like the DCML, thalamus is a region that is the hub. So this signal will go into this, because this is spinal cord. So this will also go into the ventral posterior lobe. And then from there, it will send signal into the primary somatic sensory cortex. So that's the ALS. So because this pathway, the most important function is to deliver the signal of pain, and the pain is particularly interesting and very important in our clinical practice. That patients basically feel pain, right? We have to deal with a lot of patients with pain. So we will spend a lot of time talking about that pain signal here. The ALS system is also called the spinal thalamic tract. Is a signal to transduce pain, temperature, curettage, taco, itchy, etc. And the major receptor is the free nerve ending. In contrast to the DCML, the ALS system do not provide a precise location information. So that also indicate that when the patient has a pain, the localization sometimes can be difficult. The precise localization can be difficult. Of course, we can know roughly that where it is located, but the precise location can be difficult. Right. So let's look into the pain. Pain receptor are called the nociceptor. Pain, why people feel pain, because this is a protective mechanism in our body. We want to get rid of. This is not comfortable feeling. We would like to get rid of this pain feeling. So that is a protective. And it's also a tonic receptor, so meaning that we won't adapt to it. It won't. And so we will just feel in pain if the pain source is right there. Free nerve ending is one thing unique is that it's also called a polymodality, meaning that it can be stimulated by multiple type of these stimulus. In other mechanoreceptor, receptor, they can only be stimulated by the mechano stimulus. But here it can be stimulated by the mechano, by the temperature, too hot, too cold, you can feel pain from that, or chemical, right? Some chemical will act on it to cause the pain. So there are two types of the pain receptor, A delta and type C. These two, as you can see that they are all they use different type of the fiber. So A delta use this myelinated fiber, and the type C is not. And that leads to two type of pain. A delta is a fast pain, and free nerve ending with the C fiber is a slow pain. So we have two types of pain: fast pain with the A delta, slow pain with the C. Later we will learn that their central pathway will also be a little bit different. Also, although they all go through this ALS system, but the fast pain and the slow pain has a little bit variation. We will learn that. All right, so fast pain and slow pain are, and this is basically to describe the pain from the type A delta and type C, are both located in the skin. We can also find the pain in the internal organ. That will be the type C one. So fast pain is, so in the skin, we have A and C, A delta and C. In the internal organ, it will be only C. All right. So fast pain. So in the skin, when we get pain, it will be fast pain plus slow pain. Fast pain use A delta. It's also called sharp pain, prinky pain, acute pain, electric pain. In the skin, not the internal organ. A delta is only in the skin, not internal organ. C is in skin and the internal organ. This is also this pathway is called the direct pathway. We'll learn that. Slow pains delivered by the type C. This one represent in the skin and the internal organ. Some organ has little pain receptor, such as the brain, lung, liver, kidney. This pathway is called the indirect pathway. We will learn these two pathways later. So these two pathways refer to this ALS. The internal pain is also called the visceral pain. This internal organ pain from type C is also called the visceral pain. Visceral pain because we don't know where is our organ, so it will be very difficult to localize the pain in the organ. And because of that, we will have another mechanism. It's called the referred pain. So this one showing you that even though there is pain in the visceral, in the internal organ, we don't really feel it internally. Instead, we feel it as they are in the skin. So we may feel the heart pain as the one in the for example here in the chest. Sometimes we call the heart pain a chest pain. So different. This is called so we have this referred feeling of the pain, which is in fact in the originated from internal organ, and we feel it in the skin. Do you need to memorize all this? No, you don't need to. You just need to know that the referral pain refer to the internal organ damage, and the pain is felt as if the pain is in the skin, right? So this one table summarizes the difference between the fast pain and slow pain. The receptor go with A delta or type C. Acute pain or the fast pain, A delta is the skin only. Slow pain with type C can be in the skin and in the deep tissue. They go through different pathway. One is called the direct pathway. It's also called the neo-spinothalamic tract. And the slow pain with type C use the indirect pathway. This is also called the spinothalamic tract. So this tract delivers type C pain. It's a chronic pain. It's slower delivery, take longer time because type C. Acute pain happens only in the skin, and it delivers through type A, so it's faster. It goes through the tract. It's called the direct pathway, or it's called the neo-spinothalamic tract. So what are these pathways? This pathway basically is two different branches of this ALS system. So this is the ALS system. However, here we have two types of input, type A and type C, fast and slow. When they go in, first, it will be the same, but for the secondary, it will become different. The fast pain will send signal into the ventral postulateral region of the thalamus directly. That's why we call it direct pathway, or the neo-spinothalamic tract, right? And as for the type C, it will go with the slow pain. It will not directly go into the thalamus. They will, about 80% will just stop here in the brainstem. So they will kind of diffuse here in the brainstem. In the brainstem, we have a region called reticular formation. So a lot of these slow pain stop here. We don't directly. So this is the indirect pathway. Indirect pathway would then go a different route. It don't go into this thalamus and don't go into the somatosensory cortex. If you go there, you will kind of know the location because here we have the cortex to process the location, different region in our skin. And instead, it will go into the thalamus, but a different portion of thalamus. It's called the intralaminar nucleus of the thalamus. So that's that. So this is two type of the pain coming from A delta and type C. And then one A delta go directly to the ventral posterior lobe in the thalamus. The slow pain stop, the majority stop here in the reticular formation of the brainstem. So that's that. So let's go look at that. So the first order will be the same. Type A delta, type C, they all enter into the dorsal horn or spinal cord. When they enter, they only send a short branches up and down. And so this one form, this tract is called tract of Dizar. Dizar, yeah, Dizar, yes. So they form this tract as the tract or the fourth order of the nociceptor receptor, nociceptors. And then it will reach to the second order in the spinal cord. Now, this second order will then branches out. It can be a neospinal tract that carry the fast pain from the A delta fibers to the ventral postulator of the thalamus. This is also called the direct pathway. The other one, these type C fibers, will go through the haliospinal thalamic tract. They don't project into the thalamus. They project only the halfway. They stop in the reticular formation of the brainstem. And so it's called the indirect pathway because they don't directly go into the thalamus. So let's look at this one here. So they don't go directly into the thalamus. Instead, they stop here. And from here, it will project into the intralaminar nucleus in the thalamus. So in the thalamus, we have two regions to process pain signal. One is the ventral postulator. This is the same region it processes the DCML pathway. Another region is the intralaminar nucleus. This one takes the signal of the slow pain. Sometimes this slow pain can be visual pain. In terms of survival, this visual pain is more critical than the fast pain because fast pain is skin pain. So visual pain is one that affects your internal organ. So that's more important. And when signals sent to the intralaminar nucleus, it will trigger the arousing system in our brain to make the pain become even painful. So let's look at these two in the thalamus, right here. So we talk about this one, talk about this one. Let's look at this one. So this is the thalamus ventral posterior. Sometimes we include it the lateral, but sometimes we don't. The major portion is ventral posterior. So So this one basically have A delta and all the feeling in our skin. This is important information, but not exactly like very life-threatening. The one that affects life-threatening is the one that's the slow pain from the internal organ. And so that's the one will send into the reticular formation, and from the reticular formation will enter here. This is the is right here, intralaminar nuclei. And this one will then send signal into the brain. This one will make the pain even painful. This one will activate like firing alarm. That's to tell you that something is very bad in your internal organ. You need to take care of it. So this one, the system from the reticular formation to the intralaminar nuclei is together form this system. It's called the ascending reticular activating system. This one is part of brain's principal arousal system, causing suffering pain. So the pain signal coming here from type C through these paliospinal tracts into the reticular formation right here, send signal into the intralaminar nuclei, and it will make the pain even painful. So a quick question is that, what's the components part of the ascending reticular activating system, or what's the components participate this brain's principal arousal system, right? So that is the reticular formation in the brainstem and the intralaminar nuclei. Okay, so that's these two pathways. So it's summarized here. We have two somatic sensory pathway. The DCML is the one to kind of enjoy the world, right? You can touch, you can feel, and the smoothness, etc., to enjoy the world. The other one is more like protective mechanism, the pain. So it will have two types, A delta and the C. The A delta will go through the neospinal thalamic tract, go to the thalamus, go to the brain. The paliospinal thalamic tract, or the indirect pathway, will stop at the brainstem right here. And then brainstem will send signal into the thalamus, but not the PL, not the ventral posterior VP, but it will send to the intralaminar nucleus right here. And it will not go into the somatic cortex. It will cause an arousing system in the brain. So that's that. So one, that you enjoy life, the other one protect you from the damage. Okay, so that's these two somatic sensory cortex. All right, so a couple more slides, then we will finish it today. All right, because this pain can be sometimes very unendurable, cannot endure it. Yeah, unendurable, yes. And so there are two major mechanisms that we can use or we can apply to ameliorate this pain. There are two major ones, there are several more, but the two major ones that we should know is that one is called the gate control theory. So this one is can be applied in your clinical practice. And another one is the descending analgesia producing pathway. Analgesia is the pain relieving process pathway. So we have the ascending pain signal. Then we have the descending pain relieving pathway. So there are two and more, but here we are going to talk about these two. Now, first is gate control. So basically, this mechanism is one that you can use the massage to remove pain. Why is that? It's because that tactile input, when you do the massage, when you pressure, put the pressure to it, these tactile inputs can also trigger an inhibitory signal into the pain pathway. And so when you rub it, you provide more inhibitory signal. You can inhibit the pain transduction. How does it do? So it's right here. So in this is dorsal horn of the spinal cord. Both all this sensory signal coming in, we have this touch signal from all these Messenia, Merkels, etc. They're coming in, and they will innervate with the interneuron, but they will directly send into the brain. We will also have this pain signal. The pain signal will have the second order neuron though, right here, second order neuron. Then this one will move across through this spinal thalamic tract to the opposite side into the brain, right? So that's that. These two have the will have the synapse control with these interneuron. This is GABA interneuron. So this one is an inhibitory. All right. So that's that. When there's no touch, if it's only pain coming here, inhibit this interneuron. This interneuron inhibit the secondary order. So if it inhibits it, it will reduce that inhibition, will prevent the pain signal being blocked from this interneuron. So the pain signal will be easily go through that. So this one considered as the gate. And that's why we call it gate control theory. All right. So let's say this is gate. This is gate. The pain will, maybe I have this one here. I have this one here. All right, good. So the pain signal will knock down this gate. This is the gate to control whether the second order neuron will send signal or not. Pain will knock it down, put it into sleep. So it won't inhibit the pathway. All right, so that makes sense. Now, if you have a touch, then the touch will wake up this gate. Wake up, so it will become activated. Now it can deliver an inhibitory signal, provide its function as a gate to prevent the pain signal transduction. So you will feel less pain. So that's basically is the gate control pathway. So when you try to reduce the pain feeling in the same region, you rub it, it's not just psychological effect, it has the physiological function, all right? So it will activate this interneuron to inhibit the pain transduction. Another is this descending analgesia pathway. This one coming from our frontal cortex. So the frontal cortex will, when it's very painful, sometimes this pain can be very pain, right? And so we are not like totally passive, right? We can make a decision, like we want to like kind of like just hold ourselves to endure it, because nothing we can do about it. Sometimes this pain, there's nothing we can do about it, right? So the frontal cortex, that the will of the person will be able to activate a descending analgesia pathway. The pain signal sometimes can be very painful. It can be over time. It can be even. It's called the hyperalgesia. That the pain becomes even painful because sometimes this pain trigger these arousing centers, and to make the pain affects the entire brain. So it's very painful. Now that will push the person to activate this the intention from the frontal cortex that will trigger this pathway. This is the descending analgesia pathway. So let's look at what are the components in this descending analgesia pathway. There are three major components along this pathway. One is the periventricular nuclei and the periaqueductal trochlea. So these two is right here, periaqueductal trochlea right here. You need to know that this is the region that is very near the slow pain, right? Here is the reticular formation. So this is the region to receive this slow pain. And slow pain is internal organ pain, and this is region part of this reticular activating system that trigger this arousing principal arousing center in the brain to make the pain even painful. And so from here, these periaqueductal trochlea will release a chemical. It's called the enkephalin. This enkephalin is a type of it's a type of the endogenous opioid peptide. So it's very much like taking opioid, and but it's not like you inject anything. It's naturally produced by your brain. So that is a very powerful way to block the pain transduction. So you can release that. Another one is the Raphe-Magnus nucleus. Raphe-Magnus nucleus right here. So this is also in the brainstem. In the brainstem, we have several Raphe nuclei. Here I show you that 7 Raphe nuclei. Several of them. The major neurotransmitter released from the Raphe nuclei is serotonin. So we know that serotonin can make a person feel happier, right? So this is a type of the hormone that for the person with depression, serotonin level will be low. And so this one makes you happier, can reduce pain. And once this, the major one involved in the descending analgesia pathway is this one. Where is that? This Raphe-Magnus right here. Raphe-Magnus nucleus. So that's this one here. This one will also not just release the chemical to affect the pain received in the reticular formation. It will also send signal to activate the interneuron in the spinal cord. In the interneuron of the spinal cord, here is the primary pain signal right here, going in here, this second order. We talk about another, here is another interneuron. This is GABAergic interneuron. Here we see another interneuron right here. This one is the one who will release the enkephalin again. So this one will immediately block the pain signal right at the dorsal horn of the spinal cord. So that's these three components are part of this descending analgesia pathway. So that's that. This will be another quiz question coming from here. What are the components of the descending analgesia pathway? Periventricular nuclei and periaqueductal gray, Rafi magnetic nucleus, and the inhibitory complex in the dorsal horn of spinal cord. And you need to know their neurotransmitter. What's hormone? It's not exactly hormone. It's a hormone. It's not circulating in the body, but it acts. It have the effects locally. So the periventricular, this one is here in the reticular formation. They release enkephalin. Rafi release serotonin. In the spinal cord region, inhibitory signals, neurons also release the enkephalin. Enkephalin is type of the endogenous opioid peptides. So that's that. That's why that opioid is a very powerful drug to treat chronic pain. And the sad fact is that a lot of people was originally trying to use these to ameliorate pain, but they become addicted to it. And that is a big issue. I mean, the pharmaceutical company, when they first produce this drug, they should warn. So this is like big mess that we have this opioid crisis in our country is because that people in pain and they rely on this drug and they become addicted to it. So that's sad. All right, so this one summarizes this ascending and the descending pathway of the pain. The ascending is the pain, basically is the ALS, anterolateral system, ALS system. The descending is the one that's the analgesia pathway. So that's these two. So that summarizes it. And this one summarizes this somatosensory system. And hope you get the idea that how this sensory system is picked up in our skin, and also how do they transduce signal into the brain, and how do we feel it, right? The next will be another portion of the sensory system. As we mentioned before, we will talk about the visual system. So that's that. Let me know if you have any questions.